So it's my great pleasure and joy to welcome you all today to our Zika Plan dissemination event. Zika Plan stands for Zika Preparedness Latin American Network. Our consortium brings together 25 leading research and public health organizations from Latin America, from North America, Africa, Asia, and Europe. And we are united to fight Zika virus and to build long-term outbreak response capacity in Latin America. So funded by the European Commission, we developed 15 work packages to address the complex and diverse issues of Zika. And to mark the culmination now of almost 5 years of transnational efforts, we are now hosting a series of open access public webinars featuring some of the key findings of our consortium. So today is the first of such events. In fact, it's the first of 3 events. Although, like you all, we would have preferred to meet in Brazil, where we had originally planned to hold a 3-day conference. But alas, due to COVID, we had to be creative and we came up with 3 online webinars. Herewith, I would like to thank the Global Health Network for hosting these webinars. In particular, many thanks to Raman Preet from Umeå University and to Bonnie Baker from Oxford University, who are pulling together, or have been pulling together the strings to make this webinar happen today. So now let me hand over to Bonnie for some short housekeeping announcements.
Thank you, Annelies, and welcome everyone. Just a few short housekeeping rules to make you aware of. This webinar is being recorded and the recording will be made available on the platform shortly after our session. The participant videos and microphones have been disabled. And please use the Q&A box to introduce yourself and post your questions throughout the session. There will be plenty of opportunity for your questions to be addressed, and we look forward to hearing from you. Thank you.
So thank you, Bonnie. So maybe back to the first slide. So this first seminar will have 3 topics. One is dedicated to congenital Zika syndrome, and the second topic is around the biology of Zika viruses, and the third is on the mosquitoes, the vector issues. But before we start with the science, let me hand over to our keynote invited speaker, Dr. Gustavo Mato. Gustavo is a social psychologist from the Oswaldo Cruz Foundation in Brazil, and he's coordinator of Zika Social Sciences Network since 2016. And he's also part of our sister or partner consortium, Zika Alliance. As Zika has disrupted affected communities and had a major social impact, it is only appropriate to kickstart our webinar with someone who understands the Zika-led social disruption, such as Gustavo Mato. Gustavo is also very much, has been involved in this whole process of the 3 consortia. And so thank you, Gustavo, for agreeing to give this talk. Over to you, Gustavo. Thank you.
Sorry. Thank you, Annelies. So thank you for Zika Plan as well. So it's an honor to be here and to have this opening session to highlight the social science contribution and also to explore some social and humanitarian issues related to Zika outbreak, especially in Brazil. So I will share my screen with you now. So the idea here is very briefly to give an idea of the repercussions on different dimensions and social dimensions, scientific dimensions, and also public health dimensions from Zika outbreak. So firstly, I would like to share some initial statements from social science. Zika represented and still is an uncertain issue in public health. As you know, there are many unanswered questions about Zika outbreak, his causality, repercussions, neurodevelopment, and also social economic impact, especially on women and children. Science, health, and society are intrinsically entangled in the Zika outbreak and its repercussion. This is the way that social science understands this kind of a phenomena. It's impossible to separate science, health, society, and many other dimensions in this problem. Social science are focusing on contexts, dynamics, historical, social, political, geographic, and cultural. I would like to say that we don't have one Zika, but many Zika around the world. Global, regional, and local inequities characterize the Zika epidemic and response. This is also important issue that I would like to develop a little bit with you. Zika as a political and social analysis of the invisibility of multi-disabled children and people in our world. So we have a very good colleague, Hannah Cooper from London School of Hygiene and Tropical Medicine. And she is a very good partner in our evaluation of social impact of Zika outbreak in Brazil. And she used to say that we have 1 billion person living in invisibility if we are thinking on disabled people. And after COVID-19, but getting back to Zika outbreak, it's important to say at the moment, at this very moment, every health emergency is sanitarian and humanitarian crisis. It's not possible to focus on just on, on vector and a virus and infectious disease as a biological uh, uh, phenomena. We have to focus on a complex phenomena involving society, political, diplomatic issues as we face it during COVID-19. So, also very briefly, I would like to share with you some topics that we are focused in our Zika Social Science Network, especially in the Zika Alliance Consortium that I coordinate with Jocelyn Hood, the work package focused on social science. Historical and social entanglements related to Zika emergency. Identify and analyze coordination and cooperation mechanism to contribute to a comprehensive health and social system. It is also important to say. Map the production and circulation of different discourses about Zika virus epidemic. That's why I would like to say that we have many Zika. Understand the dimension of Zika epidemic in context and on situations of vulnerability, analyzing through an intersectional perspective, gathering gender, race, and social vulnerabilities. Analyze the main epidemic repercussions of Zika in response of the health system and services in Brazil. It's also important to say that we would like to explore it in many countries in Latin America affected by Zika. Analyze and debate equity in scientific cooperation among national and international partners and the stakeholders related to Zika research in Brazil. There are many issues to explore in this situation. Improve digital methods in health using scientometric, autometric, and digital methods to map public understand perceptions and engagement on the Zika epidemic, and evaluate the economic impact of Zika outbreak on families. So this is the social science spectrum. So this is, would like to say that we can have a cross-cutting perspective on social science, since, since clinical and health care through bioethics and fieldwork research. So I would like to highlight some 3 points with you. One about uncertainties. So Zika shows that we have a kind of performatic of global health uncertainties, especially the whole of global health institutions around the world to respond to Zika outbreak. Public health uncertainties as well, especially in low and middle income countries, and clinical uncertainties. It's also involving to research and also assistance, because now in Brazil, the continuing of the health assistant depends on the continue of the research activities. So this is also important to say. So about scientific cooperation, this is the second issue that I would like to explore with you. So I have this paper published in early 2020 about Zika research response and cooperation. So we can say here that we can see here that USA, as usual, have more than 50% of the publications, and the number of corporations is related to Brazil. The Brazil is the second country that most publish on Zika during the 5 last years. So how we can continue like that, how we can find sustainability along time to keep this position, and what we could say about the other Latin American countries. In this image, we can see other Latin American countries in this most published countries through Zika. This is another work that I would like to share with you. It's from Paulo Paita and his team, also from Zika Alliance. You can see here the confirmed cases in Brazil and the concentrate of the cases in the northwest of the country. So since 2015 to 2017. So, and this is the distance and this distribution of health unities, how challenging is to attend all the families and children infected by Zika in a comprehensive way. So in a fast ways as well. So it's the distribution is very unequal in 3 selected states, in Rio Grande do Norte, Paraíba, and Bahia. So this is a big issue to face in an unequal country as Brazil. And also health professional availability. So we can see here a very good example of psychotherapists, but if you look at the important professional involved with Zika assistance, we don't have enough neurologists to take care of our children and how to evaluate the impact of the lack of assistance, especially in poor states in Brazil. So, and another issue that I would like to highlight with you is the gender, race, and social structure of inequalities. So it's not just about Zika, it's about a social structure in Brazil and many other countries. And we have many work talking and analysis and analyzing this issue. The whole and overwhelming of women and caregivers, the sexual and reproductive rights, the economic impacts on family and women, the political harassment on women's rights that we are living at the moment in Brazil, where human rights are under attack in our federal government, especially the funding to science, technology, and healthcare. The invisibility on race, social, gender, intersectionality. the whole of women in Zika scientific leadership and scientific production, funding, and acknowledgement. So there's many, many topics that I would like to highlight and to share with you to think how to face and go ahead with this kind of inequalities. So some conclusions. Nowadays, in the aftermath, it's possible to see that children affected by Zika virus have been framed and treated, to a large degree, as another segment of neglected population group, inscribing further inequities in Brazil and global health genealogy. COVID-19 difficulted health access and social protections among families. We are living a kind of drama during COVID pandemic. If you think that we are living another important and immense epidemic after 5 years of Zika outbreak. So this is the second impact for these families. When WHO declared the end of public health emergency of international concern, Zika funding was over. All of us knows about this. Health access in the most Latin American countries still depends on research funding to support cohort studies and healthcare. Danger issues in scientific production and social protections still are invisible for governments and funders. So this is some topics that I would like to share with you and probably could stimulate further discussions during this webinar. So this is my tribute to women in science and women that are resistant in this very moment in Brazil. You can see here in this picture many, many women that are leading scientific research groups in Brazil, and also the very brave women that fighting and represented mother associations in Pernambuco, Bahia, and Rio de Janeiro. And other colleagues here that most of them are watching this webinar. So thank you very much. If you would like to share, to see other production of our group, this is the link. It's based on the Global Health Network website, Zika Social Science Network. Thank you very much.
Thank you, Gustavo. You captured the pertinent issues brilliantly, and thank you again. And I also want to thank you that you will carry on with the legacy of Zika Plan and Zika Alliance and Zika Action, even after our projects end. And so that's also very important. Now, let's watch a film together. This film is entitled Hope After Zika and was produced by Zika Plan partners at a London school in 2018. The film is about community engagement and support and will set the scene why pioneering research for Zika was and still is so important. Thank you.
João e Verônica moram em Salvador, Bahia, com sua filha Liz, que nasceu em 2015.
Tive uma gravidez tranquila, não mostrou nada. Depois que ela nasceu, foi que os médicos vieram conversar. Quando a gente teve a certeza de que ela tinha microcefalia, ela já estava quase com 5 meses. Eu particularmente, me senti emotiva, assim. Eu imaginava, com a estimulação precoce, vai demorar, mas ela vai fazer tudo.
Liz, como milhares de outras crianças de sua idade, nasceu com a síndrome congênita do vírus Zika. Sua família é uma de muitas pelo Brasil que frequenta um grupo local de suporte onde pode compartilhar sua experiência e receber conselho. Os grupos são assistidos por um profissional de saúde e apoiados por pais voluntários como Silvia, cuja filha também foi afetada pela síndrome congênita do vírus Zika.
Quando eu soube do projeto, eu achei maravilhoso. E a família não, a família tem uma experiência e o projeto traz isso. Ele junta a experiência da família com a experiência do terapeuta. Os assuntos discutidos no grupo são vários. A gente tem uma sessão de posições e movimentos. Temos a sessão de comer e beber, que é a que eu mais gosto, mais me identifico.
Depois que a gente começou a frequentar o grupo, mudou a nossa forma de alimentar, porque ela se joga muito para trás e às vezes ela sentia dificuldade em engolir e a gente deixava, mas a gente aprendeu no grupo que isso dificulta muito, né? Ao beber uma água, a engolir a comida.
Os grupos também oferecem uma fonte importante de suporte psicológico para as famílias. Depois do choque de um diagnóstico, há um período de ajuste para os pais que pode ser bem difícil.
Nós contamos como descobrimos que as nossas crianças são portadoras de Zika, como nos sentimos naquele momento em receber uma criança portadora do Zika vírus. Falamos sobre a nossa aceitação, procuramos entender se, por exemplo, eu ainda estiver nesse momento de luto, né, as facilitadoras nos orientam a entender que essa mãe precisa de mais tempo ou que essa família precisa de mais tempo para passar por esse momento de luto. Ou não, que ela já venceu o luto. Como foi que ela venceu? Qual foi as estratégias que essa família utilizou para vencer esse momento de luto?
Depois que a gente começou a frequentar o grupo, a gente houve um sentimento de apoio, houve um sentimento de que nós não estamos sozinhos.
Você não precisa ficar só. Você pode se conectar com outras famílias, compartilhar suas experiências, receber apoio ou oferecer apoio para outros. Comece entrando em contato com o Movimento Zika 21 2239 9379 ou visite o website www.movimentozica.org.br. Você pode se juntar a um grupo de suporte ou até começar um grupo na sua área. A vida para sua família ainda pode ser gratificante e cheia de amor se a sua criança é afetada pelo Zika.
As crianças nos inspiram a ser humildes, né? A refletir, fazer uma autoanálise sobre a nossa existência, o que de fato tem valor para a gente, o que de fato é importante. É tão bom, é tão lindo ver o sorriso de uma criança, é tão lindo sentir o toque e saber que a criança está bem e que ela é amada por todos. Eu acho que ela veio para confundir os egoístas e trazer humanidade para a gente.
Well, that was an impressive film and reminds us and motivates us to continue in our Zika research to make sure that we do better when it does return. We will now start with the science, and it's my pleasure to introduce Associate Professor Elizabeth Brickley to you. She is Associate Professor at the London School of Hygiene and Tropical Medicine and will be chairing the first session on the full spectrum of congenital Zika syndrome. Thank you, Elizabeth.
Thank you, Annalise. And thank you everyone for joining us. So today I'll be talking about Zika virus infection during pregnancy and congenital Zika syndrome. When the cluster of children born with microcephaly was detected in the northeast of Brazil in late 2015, a task force of Brazilian public health experts known as the MIRG, the Microcephaly Epidemic Research Group, was rapidly assembled to get to the cause of the outbreak. The MIRG researchers, including Professors Celina Turki, Ricardo Ximenez, Democrito Miranda Filho, Talia de Araujo, Laura Rodriguez, Ulysses Monterroyos, Viner de Souza, and Maria Albuquerque, among others, coordinated with state and federal health officials, as well as investigators across other affected regions in Brazil, to harmonize study protocols and initiate a series of groundbreaking epidemiological investigations that connected the microcephaly cases to Zika virus infections during pregnancy, ruled out alternative hypotheses for the causes of the epidemic, including larvicides, and provided the first clinical descriptions of a new disease, congenital Zika syndrome. What had previously been thought of as a benign mosquito-borne virus was soon recognized as a global threat capable of causing severe teratogenic effects. Building on this initial body of research and with key support from the Zika Plan Consortium, our team of investigators has initiated and followed up a series of clinical cohorts across Brazil to study Zika virus infections in pregnancy. The Zika Plan affiliated cohorts include the Microcephaly Epidemic Research Group's Pregnant Women Cohort and Pediatric Cohort in Pernambuco State, the Zika IFF cohort led by Professor Maria Elizabeth Lopez Moreira in Rio de Janeiro, and also a pregnancy and birth cohort in Goiás State led by Professor Marilia Dalva Turki. Our Zika Plan affiliated research has had three primary areas of focus. Our first area of focus was to shed light on Zika virus infections in pregnancy. In particular, our research has contributed to the development of a diagnostic algorithm for identifying maternal infections, yielded new insights regarding the vertical transmission of Zika virus, and provided some of the most robust estimates to date on the absolute risks associated with congenital Zika virus infections. Our second area of research has been on the prognosis and health needs of children with congenital Zika syndrome. Specifically, we have worked to understand the full spectrum of the disease, characterizing the structural abnormalities, functional impairments, and neurodevelopment of children with congenital Zika syndrome. And our third strand of research, which was led by my colleague, Professor Hannah Cooper at LSHGM, focused on the social and economic impacts of congenital Zika syndrome. So in addition to its direct impact on the health of congenitally infected children, Zika virus infections during pregnancy can have profound implications for the well-being of mothers and other caregivers. And this vital social science research has highlighted challenges related to support systems, gender inequalities, maternal mental health, and healthcare access. In addition to collaborating within the Zika Plan Consortium, our team of investigators has been actively engaged with the global Zika research community. And one notable initiative is the Zika Brazilian Cohorts Consortium, which is led by the Microcephaly Epidemic Research Group in partnership with the Brazilian Ministry of Health. And the ZBZ Consortium brings together pregnancy and birth cohorts of children with congenital Zika syndrome from across the country of Brazil in order to facilitate large-scale joint analyses of the data. In addition, the data that we've generated through our clinical cohorts has fed into other large-scale individual participant data meta-analyses, including an initiative through the European Commission Vertical Transmission Study Group with our partner consortia Zika Alliance and Zika Action, and also the WHO-led Zika Virus Individual Participant Data Consortium. And I just wanted to briefly highlight a few of the really key outputs from this work. And the first one is to note the MERG pediatric cohort, which has now been followed up for 5 years, is the largest single cohort of children with congenital Zika syndrome and Zika-related microcephaly. Another key output is the scientific articles that have been produced by studying these cohorts, which include more than 40 publications with another 15 in preparation. And finally, we've also done a lot of work around expanding the efforts and thinking about epidemic preparedness through research capacity strengthening, including with the training of more than 30 master's students, PhD students, and postdoctoral scientists across our institution, and also being involved in epidemic response training internationally through MOOCs and other outbreak simulations. Our research has also fed into policy, in particular through guidance of the Brazilian Ministry of Health and the WHO PAHO. And with that, I want to introduce our speakers for today. And so our first speaker will be Professor Maria Elizabeth Lopez Moreira, who is a Fiocruz researcher specializing in pediatrics, child growth, and neurodevelopment. After that, we'll be joined by Ricardo Arias de Alencar Ximenez and Demacro de Barros Miranda Filho from the Microcephaly Epidemic Research Group. So thank you very much. There are many amazing scientists behind this work, but I'm really glad that we'll get to hear from 3 of them today. So with that, I'll pass over to Professor Moreira.
And first of all, thanks for inviting me to present our results. You have 5 papers published about the neurodevelopment of these children. And I put in the last slide, but I would like to begin to thank all the people that help us to bring these children to visibility, because they usually be invisible. And just now, they are not in spotlight anymore, and they are still having problems, and they still needs to very hard follow up in order to bring to them some hope and some clinical results. This is results of a court. Then these courts are registered in the clinicaltrials.gov. We enrolled 296 children, and 96 of them had microcephaly at birth of any other complication as calcification or seizures or arthrogryposis, something like that. And you have another children without problems at birth. They was born completely with the clinical normal evaluation. And nowadays you have 146 children in follow-up, and you already 17 deaths. Of course, all of them are in the group of microcephalic children. And during the follow-up, we did some measurements of gross antibody composition, neurodevelopment using Bailey tests 3rd edition, high and hearing exams, and clinical evaluations. This is the 2 more important publications that you have, one in the Nature and another one in the New England. And one of them is the children with 1 year old, and another one 2 years old. And you continue to follow these babies, and you want to follow them from now until the school age. And our result is very worried, because you note that these babies that was born apparently normal, they used to have some delay in development. Most of them, around 30%, had some delay in language domain in the Bailey tests. Some of them had some cognitive and motor delay, but mainly they have language delay in language, in the language domain. This is very important, because you know that follow this, the language delay, you can have the cognitive delay. Then they are arriving the school age. Then that's very important to define risk and to send them to have some intervention in order to minimize their problems, their impairments in the school age. Then the results about the neurodevelopment are language delay, especially receptive language, was found in infants prenatal exposed to Zika virus and asymptomatic at birth, which might indicate future learning difficulties. Neurodevelopmental dysfunction, mainly in the language domain, was unrelated to the gestational period of exposure. Because you know that microcephaly used to be more usual in the mothers, in the babies from mothers that have the Zika virus in the first trimester of gestational age. But this type of language delay is not related to gestational period of exposure. The exposure to Zika virus in pregnancy can affect the neurodevelopment of children who were asymptomatic at birth. You also noted that the head circumference of these babies with delay is smaller than in the babies without any delays. They are not microcephaly, but they have a smaller head circumference at birth for gestational age. In conclusion, a normal assessment at birth after congenital Zika virus exposure does not guarantee ongoing normal neurodevelopment in these children. Exposed infants should have regular development of ophthalmological and hearing evaluations, even if initial exams or evaluation are normal. Early detection of risks can accelerate the referral to children for early intervention. And you know that these children have some neuroplasticity. We strongly believe in neuroplasticity. You can do something using some intervention, neurodevelopment interventions. Understand the full spectrum of neurodevelopment abnormalities has important in public health and education system implications. Then you conclude that these children need to have neurodevelopment assistance because you can identify early risks and send them to have some interventions. And our perspectives from now is continue to follow neurodevelopment of these children from 3 years old to school age. You know that the new test cannot be daily anymore. You need to send these tests for VIPS tests or other tests. And another thing is to compare neurodevelopment of these exposed children with non-exposed children of the same age. Of course, this is a big problem for us because you are using clinical mother symptoms at pregnancy and serological tests from mother and child just now. And you are going to have PRNT2 from these children. And I hope to have this comparing group. But you know that in the birth reports from Brazil, begin before the Zika virus epidemic, you used to have at 10% of the delay language domain. Then now you have almost 30%. Then maybe this is the causality of this probably is really the exposure to Zika. But you hope to have this comparing group using child with the same age. And I would like to thank Zika Plan, Wellcome Trust for London School of Hygiene and Tropical Medicine Health, CNPq, FAPERJ, Brazilian Minister of Health, Fiocruz, NIH with RO1. Without them, it was impossible to follow these children neurodevelopment because they are followed because you have assistance in research. Our system doesn't have regular help with these neurodevelopment tests for everyone. And I'm very thanks. I would like to thank a lot of all this financial support to these children. And thanks a lot for this. Then that's it. I would like to finish with this thanks and thanks to my team, all the team that work with us and the Instituto Fernandes Figueira from Fiocruz, Rio de Janeiro. Thanks.
Thank you so much, Vivek. And I see that we do have a question, but we're going to save them until after all three speakers, and then we can answer them together as a panel. And so with that, I'm going to pass along now to our next speaker, who is Professor Ricardo Ximenez, who is a MERG researcher specializing in epidemiology and a professor at the Federal and State Universities of Pernambuco. And Ricardo will be presenting on the risk of adverse outcomes in the first years of life in children born to mothers exposed to Zika virus infection during pregnancy.
So, good morning or good afternoon. And I'd like first to thank Zika Plan for the opportunity to present here the results of the work we have been developing. My talk will be on the risk of adverse outcomes in the first years of life in children born to mothers exposed to Zika virus infection during pregnancy, and I'm talking on behalf of the MERG group. To be able to talk about the risk of adverse outcomes after infection during pregnancy, it was necessary first to establish a definition of what was exposure during pregnancy. So we worked on categorizing these women that had rash and were notified to the health secretariat of the state of Pernambuco during the Zika epidemic. We categorized them either as positive or as suspected. And these two major categories, they included subcategories depending on the results of a molecular test, PCR, and of serological tests. Two markers of recent infection, IgM and IgG3, and one marker of previous infection, PRNT. And these tests were performed sequentially during pregnancy. Here we present the main characteristics of these 501 women that we followed until delivery. So they were young women. The median age was 26 years. Most of them had secondary education. Most of them belonged to a lower social class. Most of them, again, had a previous pregnancy, but the report of children with malformations from previous pregnancy was low. It was only about 3%. The frequency of smoking was less than 10%. The frequency of illicit drug use was less than 2%. And most of these 501 women were categorized as being Zika virus positive, and most of them in this group of positive women were both evidence either based on PCR or based on the serology. From now on, I present the absolute risk of the adverse outcomes of the children born to these mothers. So the absolute risk of microcephaly was around 3%, and it was not different when we consider the women that were categorized as positive or the whole group of women. We mean the positive plus the suspected. Another point that I would like to highlight is that we observed that microcephaly is not a homogeneous entity. In fact, microcephaly itself is on a spectrum, as we observed children with proportionate or disproportionate microcephaly, and with or without imaging, ophthalmological and neurological abnormalities. And these results are consistent with the results of other cohorts in a case control study that we conducted in Pernambuco. Here we presented the risk of image alterations, and the risk of image alterations was about 7%, and it was not different when we consider just the group of positive women and the group of positive plus the group of suspected. Calcification and ventriculomegaly were the most frequent abnormalities that we found, and these abnormalities, they were also very frequent in the case series of microcephaly that were reported in the literature. Of course, in the case series of microcephaly, there is a wider spectrum of image abnormalities in these children. In relation to the neurological abnormalities, the risk of neurological abnormalities, it was around 5%. If the assessment of the children was done, when it was analyzed at the first evaluation, it was around 5%. And when we consider the whole period of follow-up, it raised to 13%. So it's not surprising that there was this increase during the period of follow-up, because some findings like epilepsy, like motor and material milestones may be detected only in a later age of these children. The frequency or the scale of ophthalmological abnormalities was around 7%, and it did not differ between the two groups of mother, and it did not vary if the detection was performed, was obtained at the first evaluation or at any time during the follow-up. The risk of abnormal auditory brain stem response was about 5%, and again, it did not differ if we consider any of the two groups of women, and if we consider if it was detected at first evaluation or detected at any time during the follow-up. The risk of dysphagia, I mean reported dysphagia by the mothers, was around 2%, 2 to 3%, and then again, it did not differ if detected at the first evaluation or at any time during the follow-up, and in both groups, in children born to both groups of women. The results of these slides, I think that they are very important because they show that the risk of presenting at least one of the main abnormalities compatible with the congenital Zika syndrome is about 20%. And 20% when detected at first evaluation, and about 30% when detected at any time during the follow-up. This slide also indicates that the individual abnormalities, they are more frequent than the combined abnormalities. And here we selected just the main abnormalities, which are microcephaly, imaging, neurological, and ophthalmological abnormalities. In relation to the combined abnormalities, the frequency that we observed, it was around or less than 2%. So the risk of presenting microcephaly and neurological abnormality associated with imaging or ophthalmological abnormality was below 2%, as well as the risk of presenting neurological abnormality associated with imaging or ophthalmological abnormality. And these figures were similar when we consider the whole period of follow-up, and when we consider the group of children born to mothers who were positive, and also the group of mothers who were suspected of a Zika virus infection. So the main conclusions of our results are that the frequency of microcephaly was approximately 3%, so it is relatively low, and it is consistent with the finding of other studies who found frequency of microcephaly of less than 6%. Another important finding of our work is that the risk of presenting at least one abnormality compatible with congenital Zika syndrome was around 20%. Our findings lie between the study of Brazil, who found a frequency of 50%, and the studies of Reynolds and Roen, who found a frequency or a risk of about 10%. Another important finding is that isolated manifestations occur more frequently than in combination, and in fact, that combined adverse outcomes, they occur in less than 3% of the children born to mothers who had Zika virus infection during pregnancy. And using the classification of exposure, we were able to study, to estimate the risk of adverse outcomes according to the degree of evidence of Zika virus infection during pregnancy. So I would like to thank Zika Plan for the partnership and for the support. And I'd like also to thank the other supporters of the work that the MERG has been developing. Thank you.
Thanks very much, Ricardo. And our next speaker will be Professor Democrito Tabaro Miranda Filho, who is a MERG researcher specializing in infectious diseases and a professor in the Medical Sciences and Health Sciences postgraduate program of the University of Pernambuco. Democrito will be presenting on the contributions of the Microcephaly Epidemic Research Group pediatric cohort to the understanding of congenital Zika syndrome spectrum.
I'm very grateful to be here to present our contributions to the understanding of the congenital Zika syndrome spectrum. In 2016, we published these 4 papers that contributed to an initial description of microcephaly. In a large case series, these 104 patients. And we also proposed an initial description of, at that time, a presumed congenital Zika syndrome. And we showed other less typical findings, such as microcephaly without calcifications or with normal brain imaging and intrauterine growth restriction in our case control study. So now I will show what else we have done after the Zika Plan kickoff meeting here in Recife in October 2016. So this is our cohort. It is composed by 4 groups of children recruited in different situations. These 4 groups. These, with almost 200, have been followed since the beginning of the epidemics, and almost all of them have microcephaly, are outpatient groups. And this other group have 80 participants are from our case control study. 34 were cases with microcephaly at birth, and the others are control, not neurotypical children. This third group are born to mothers who had rash during pregnancy that composed the MERG pregnant women cohort that Professor Ximenes presented before. So in this figure resumes part of the results of this article in which 91 children with Zika-related microcephaly were sequentially evaluated for epilepsy, and the cumulative incidence of epilepsy that we found in the first 2 years of life was about 71%. And the most common type of seizure was spasm epileptic without hypsarrhythmia. These are the most important. In this paper, we show the frequency of oropharyngeal dysphagia in children with Zika-related microcephaly. It was almost 80%. And in children born to mothers who had PCR positive for Zika during pregnancy, it was 80.6%. And this frequency is higher than expected for healthy population in general. This was a study to evaluate neurodevelopment with a screening test, the SWIC, in 4 groups of children, these 4 groups here. And what we found that was almost 100% of the children with severe microcephaly were classified at risk for retardation according to the test. And there was also a high frequency of children at risk among those with moderate microcephaly. And the risk of retardation in this group that was only exposed during pregnancy but without microcephaly was similar to the neurotypical control groups. Other component of congenital Zika syndrome we recently identified was cryptorchidism in children with Zika-related microcephaly. From 22 males examined, 8 had cryptorchidism, and about 80% of the testes were palped in the inguinal region. Other 7 boys that were not included in this case series had retractile testes. This is another kind of finding is also named the false cryptorchidism, because you can put temporarily the testes in the scrotum, but after that they were retractile to inguinal region. The most important findings in surgical findings of that series were a high prevalence of testis epididymis dissociation, showed here and here, a low mean of testicular volume for their ages, so like hypertrophy. And another one, it was ectopic gubernacular insertion in all cases. All cases had a gubernacular insertion that suggests that these may be explain the mechanism of cryptorchidism. Other recent finding is a relatively high frequency and early presentation of adenoid hypertrophy in children with also Zika-related microcephaly. It was about 54% of those with symptoms of respiratory obstruction that were examined. We found adenoid hypertrophy very severe. 13 of them were submitted to surgery, and in 11, there was complete resolution of symptoms. And finally, we recently also described the finding of different types of endocrine dysfunction in 30 children with Zika-related microcephaly. This is the first study in the literature to discuss endocrine disorders, and the main dysfunctions that we found were variants of early puberty, or pubarch or adenarch, short stature, hypothyroidism, obesity, or these kind of different combinations that we show here. So our conclusions are there is a spectrum of severity in the Zika-related microcephaly, and the congenital Zika syndrome is not yet totally understood. In addition to damage to the central nervous system and its direct consequences, such as epilepsy and mental retardation, children with severe Zika-related microcephaly may present other anatomical or functional impairments. Some of these impairments are dysphagia, cryptorchidism, retractile testes, adenoid hypertrophy, and endocrine dysfunctions. So next steps is necessary to say that children known to be affected, as well as asymptomatic children at birth or in their first years of life, must be systematically monitored in order to identify dysfunctions or late manifestations or development problems. So we have to thanks to the Zika Plan Fund and the other supporters of our groups and all our collaborators and camp field workers. Thank you.
Thanks very much, Demarcato. And could I invite Bebet and Ricardo to join us as well? And now we'll have an opportunity to answer any questions that you might have. And for our audience members, if you could please put those into the Q&A function, we'll start off with those questions. Great. Well, thank you so much, everyone. That was really amazing and an incredible research that's been done over the last 5 years in describing this new disease and learning about how the vertical transmission of Zika infections in pregnancy work. The first question, I think, is probably going to Professor Moreira, and it's a question about the children who were born apparently asymptomatic at birth. And do you have a sense of what the estimated proportion is of the children who we know that they were exposed to Zika during pregnancy, but then were born without any apparent neurological complications?
Around 70% doesn't have anything. They was born normal and they have the neurodevelopment test completely normal from birth to 3 years old. Then that's a good note. This is a good news for the mothers, but we think that you need to follow them at least to school age in order to detect the risks early and maybe if they need to send them on some interventions.
Great, and I think that's a good follow-up point as well, is that you had mentioned that the children are likely to have a great deal of neuroplasticity, and so there's having the neurological interventions and stimulation for the children is very important. And perhaps Democrito, you might want to weigh in this as well. But what sort of interventions are being shown to be the most effective for these children?
Yes, we are doing the speech language interventions using some programs with them and physiotherapists intervention, because you know that sometimes you just need to correct the posture and they improve a lot. And the Juntos program, I don't know if, I think that you know about that. This is a program with Hannah Cooper and Loveday and some Tracy Smith. And we introduced this program here in Brazil, but of course you are using this program to children with the high risk for cerebral palsy, especially the microcephalic babies. And this program is going very well, and the mothers are very satisfied with the results. And the fathers used to go to see the classes too. But for the other children, these children that was born apparently normal, we don't have a specific program. You need to detect the problem in order to send them to have some intervention. In our population here in Brazil, the results from birth cohorts from Pelotas and Ribeirão Preto, Brazil, they usually show the 10% of the delays in language. And of course, you are seeing that the higher delay in language in the Zika exposure to children. But of course, the idea is to have a control group. In our country, you are programming this, but it's almost impossible because you don't have good serological tests until now. And to choose some children that was born in the epidemic period of time and at the same time could be almost impossible. But just now we are trying to do the IgM and the IgG in these children, in the mothers, and try to have some babies that you can say that they didn't have exposure to Zika, and try to follow their neurodevelopment.
Great, thank you. And I think our next question is for Ricardo, and it's a question about whether or not the absolute risks that you described were derived from during or after the Zika outbreak that occurred in Brazil.
Okay, so we started recruiting these women for the cohort of pregnant women as early as February 2016, so just after the peak of the microcephaly epidemic. So if we had started before, maybe we would have a larger number of women, but it does not affect the risk. Among those infected, we do not think that the risk would change over time. I'd like to call the attention to one point that people sometimes get a bit confused, is that we are talking about the risk of adverse outcomes. So it's not, it's different than what people are more used to read about, which are the cases of microcephaly. So for the children with microcephaly, it is more frequent, it's more common to present more than one abnormality. But as already explained, microcephaly is has a spectrum itself. There is a variation in the microcephaly. But more important than this, I'd like to call their attention is that if the child does not present microcephaly, the risk of presenting more than one abnormality is below 3%. So the risk is below 3% of presenting combined abnormalities related to Zika virus infection during pregnancy.
Thank you. And to follow up on that, a question has come in around Zika-related microcephaly in other regions of the world. And I wondered if any of our panelists could weigh in on whether or not you have a sense of whether or not you're also seeing Zika-related microcephaly occurring in other regions of the world, or is it being misdiagnosed?
So we have publications describing Zika-related microcephaly in almost all countries in Latin America and Central America, and with the same characteristics. And the other publications about cohort studies with pregnant women, they show a similar risk of microcephaly in this that occur in Zika virus.
The variation that we found in the clinical presentation of microcephaly in our study is similar to what was described in previous study. In previous studies, it was also found microcephaly with a proportionate or disproportionate proportionate or disproportionate microcephaly with or without imaging, neurological or ophthalmological abnormalities. So it seems maybe some author did not call the attention to that point, but if you go through their papers, if you read their findings, in these other studies, there was also a variation in the clinical presentation of microcephaly. So it seems that it does not differ from one place to the other.
Thank you. I wanted to pick up now on a point that Gustavo had raised in the really nice opening session, which was talking about the impacts of the COVID-19 pandemic on the children with congenital Zika syndrome and their families. And I wondered if you could weigh in on what you have seen within each of your cohorts. Yeah, Gustavo, it would be great to hear from you as well and what your perspective is.
Okay, I'm sorry. I was thinking that
perfect.
it's just for you. No, it's okay. The impact, I also use it to talk with Maria Elizabeth Moreira, and we are very worried how to support the cohort student without funding. So this is a very important impact on how not just to keep our study, but also to support and give access to the family and children. So I think that this is a very critical issue that we could have to discuss globally, because there's a lot of inequalities to support scientific research in our country at the moment. So to give you an idea, Brazil has cut something about 70% of the science and technology budget from the federal government. So, and now we are living during a COVID pandemic, but we continue to live to give assistance to children with Zika congenital syndrome. And we also have an important dengue and chikungunya epidemic at the moment. So the problem didn't disappear, right?
Yes.
This is a very complex issue that we need to continue to discuss, especially with inequalities within country in Brazil and globally.
And yes, I would like to comment this. You know that these children are not in spotlight anymore. And the children with microcephaly continue to need hospitalizations. They are having seizures. They aren't have the medications that they need to treat the seizures. And you have a discontinuation of these offers to this support. And I really think that the children with microcephaly need this to have more assistance, and maybe they need to come back to spotlight. They can't be out of the spotlight because they really need assistance. And my worry is about all children that was born in the pandemic period, because you know that 70%, almost 70% of the mothers would have Zika without symptoms. And maybe they can have some delays in development, and they need to be followed up. They need to have adequate follow-up in their development. And you know that without this assistance in research funds, I really don't know how to do it. That's a big question, because 30% of delay in language is very strong, and you need to have some attitude in order to improve this, in order not to have impairment in the school age.
Thank you very much. And Gustavo, you had your hands up. Do you want to weigh in?
No, very quickly. So just to highlight 2 points, right? One of them is also related to what Maria Zelebete Moreira, it's our Bebete, said. So we didn't include in the prenatal orientations about Zika prevention. So we are running now a WHO research about risk communication on current pregnant women, and we don't have anything in the prenatal about Zika, even information, even how to prevent, and also serological tests or some diagnosis tests during pregnancy. So this is very, very critical about after our outbreak. The second point is not just about Zika, but other multi-disabled children in Brazil, because we don't have a good, it's not only in Brazil, but we don't have information system adequate to identify these cases. So we don't have any idea how the amount of people are born with multiple disabled symptoms. So this is very, very critical. And I think that globally we need to discuss this, especially in low-income countries.
Thank you. Yes, Ricardo.
Yeah, I'd like just to make a point of the relevance to continue following these children. I mean, it's very important to study the impact of the COVID-19 on the development of these children, because some achievements that were reached, now these children are losing these achievements because they are not being stimulated properly. It's not possible to stimulate them properly during this period of COVID-19. So it's very important to document and to think of strategies on how to deal with this situation. And I think that it's also very important in relation not only to the children, but also to the mother. I mean, these mothers, they are not working, they are taking care of their children full time, and they also do not have access to the health facilities because of the COVID-19. So there is an important impact on the life on the history of, on the trajectory of these mothers and on the development of the children.
Thank you all. One thing that's really struck me about the Zika response is the scale of collaborations within Brazil and also internationally. It's really remarkable and kind of a template for other emerging infectious diseases in many ways. And I wondered if you could weigh in about what you see as kind of the secrets to success for international collaborations and within country collaborations during emerging infectious disease outbreaks.
This is for me or?
For all of the, any of the panelists. It'd be great to hear from you, Gustavo.
Okay. No, just a brief comment. As I show you in my presentation, the Brazilian cooperation was very intense, especially with the US and other countries. So, but during the cooperation, we have many new experience to face as data sharing, how to deal with data sharing globally, because when we receive international funding, it's compulsory to share the data. Also, pathogen sharing, it's a very sensitive issue. So how to create a biobank and how we can deal with patents and intellectual property and authorship. So this is also important when Brazil start or intensify international cooperation about after Zika outbreak. And now we use the same network to improve COVID research cooperation. So it was very, very useful. And we learned a lot with the Zika outbreak to respond to COVID research and cooperation internationally.
I think that one very important point is to work very early on harmonizing protocols and harmonizing instruments that will be used to assess the effect of the infection. This is what made it possible to analyze the data together for the Brazilian consortium and also for the WHO consortium. And this is a very important step in the beginning of every epidemic, is the harmonization of protocols and of instruments. It's not possible to conduct the multicentric studies during the epidemic, but it's possible to harmonize the data, to harmonize the protocols, and then make the data comparable and analyze them together.
I agree with you, Ricardo and Gustavo. And this is a challenge for us in the Zika times. And now you are, as you learn with Zika, it's a little better with the COVID researches. And you know that I think that you have here in Brazil a biodiversity law that are very difficult to us to share samples with the other countries. And this maybe could contribute with this absence of the serological tests, good serological tests. And this is a big challenge for us to share samples of blood, urine, everything to other countries. Is very bureaucratic. And it's very difficult to work with this type of thing.
And so I just wanted to say thank you so much again to all of our speakers. We really appreciate it. I lost track of time there with the Q&A. It was such an interesting conversation. But now I'll pass over to Annalise. Thank you, everyone.